The meeting's called to order. I want to first thank everyone for being here, particularly our panelists. The subcommittee today is holding the first in a series of hearings entitled Making Healthcare Work for American Families. These hearings will help us better understand issues important to the healthcare reform debate, such as quality, cost, coverage, and prevention. And today we're focusing on how to design a high-performing healthcare system, which implies that our current system is underperforming. Indeed, as it is presently structured, the U.S. healthcare system is incapable of consistently providing access to quality and affordable care to every American. And a large part of this failure can be attributed to our nation's growing uninsured population. According to a new report on the uninsured by the Institute of Medicine, who we'll hear from later today, 47.5 million Americans, or an estimated 17.2% of the non-elderly population, went without health insurance in 2007. As we move forward with health care reform, we must understand that our failure to insure 47 million Americans has significant consequences for the health system as a whole. Our nation's growing uninsured crisis impacts us all, regardless of our own insurance status. If we're to design a high-performing healthcare system, the foundation of such a system has to ensure access to quality and affordable coverage for every American. But the problems we face with our healthcare system go beyond coverage issues. Our healthcare system is woefully disorganized, so much so it's hard to characterize it as a system at all. There's virtually no coordination of care among providers. Patients are often handed off from one provider to another. In the process, information is lost, inappropriate treatments or tests are ordered, and medical errors occur. This is particularly a problem when it comes to patients who suffer from chronic conditions and are under the care of multiple providers at any given time. Researchers have suggested that part of the problem stems from the fragmented way in which we finance the delivery of health care services. We pay providers based on volume, regardless of the quality of the care or service provided, and regardless of the outcomes. Furthermore, there's little incentive for providers to follow up with a patient after they've provided treatment, or to coordinate care among multiple providers or between different healthcare settings. What has this disorganization created? Well, the United States spends more on healthcare per person than any other industrialized nation, and yet we do not enjoy better health outcomes by almost any measure. And within the United States, there are vast disparities in how healthcare is delivered among the different communities. Clearly, we're not getting the most value out of our healthcare dollars. The erratic and chaotic manner in which our healthcare system is organized can't continue. We need to find a way to reorganize the healthcare delivery system in a way that improves quality and efficiency, thereby driving down costs. And there are a number of options on the table. For example, the President's budget contains specific proposals that would change the way Medicare pays for and delivers health care, including 1, reducing readmission rates at hospitals, 2, providing performance-based payments for physicians that coordinate care for Medicare beneficiaries, and 3, promoting coordinated care between acute and post-acute care settings through bundled payments. Now, I know we have MedPAC here today. I'm happy that they're here because they've done work in many of these areas, as well as other areas like the medical home model. As Chairman Hackberth notes in his testimony, Medicare can be a leader in reforming the healthcare delivery system, but changes to the way Medicare delivers and pays for health care will only take us so far. We need fundamental change through the entire healthcare system in order to achieve our goals. Now, one of the best examples of change, I think, was in the economic recovery bill. As you know, there's a pot of money for healthcare information technology, and that's certainly an example of the systematic change we need. As more physicians are able to adopt and use HIT, we can facilitate greater communications among providers and thereby increase the coordination of care. By passing the Economic Recovery Act, we started the process of modernizing our healthcare system by investing $19 billion in HIT. But not everything has to be as complicated as moving our healthcare system into the electronic era. There are simple changes that will produce dramatic effects. For instance, I believe that by focusing more on primary care, coordinated care models, and prevention, we can achieve greater savings and efficiency within our healthcare system. And again, there are prevention and wellness measures and pots of money in the Economic Recovery Act as well. If we're successful in redesigning our healthcare system so that it performs better, there will be great rewards. Aside from the potential to improve health outcomes, a more efficient healthcare system that pays for quality services will help drive down costs for American families, businesses, and the federal government, all of which are struggling with the escalating cost of healthcare. Indeed, healthcare reform is fiscal reform. Those of us who've been paying attention to the President over the last month or so, he constantly talks about healthcare reform being fiscal reform and the need to bring down costs if we're going to effectuate an economic recovery and expand coverage for all Americans. We can't restore the financial health of the nation and American families without tackling our broken healthcare system first. So let's get started. I just wanted to say, many of us on this committee attended the President's Healthcare Summit last Thursday. I was tremendously impressed with the fact that almost everyone said that we needed health care reform now. They did not want to wait. And almost everyone said that the cost and bringing down costs was an important part of any change that we're going to effectuate. I used to be very proud of the fact that I could go around and saying I was involved in health care policy and that we had the best health care system in the world. I don't believe that anymore. And I think the time to act is now. And so we're going to begin today. I now recognize our ranking member, Mr. Deal, for an opening statement.
Thank you, Mr. Chairman. I want to thank you for holding the hearing today. I want to thank both panels of witnesses who are going to testify. In particular, I would like to go ahead and welcome, even in advance of his official introduction, Dr. Todd Williamson, who is a neurologist from Georgia and is president of the Georgia Medical Association. He'll be on panel 2, and thank you for allowing him to testify. You know, when you talk about health care, you're talking about how to wrestle a porcupine. And the problem I think we have encountered is that we have known different ways to deal with this issue in small pieces over a long number of years, and we have failed to come to grips with dealing with those pieces. And now we are trying to deal with the system as a whole and talk about how bad the system is, even though we have not taken advantage of the opportunities to make it better incrementally. I'm always concerned about major reforms, especially of a segment of our economy and of societal service as large as health care. But we are now apparently on the brink, for whatever reason, dereliction of duty in the past or whatever, of having to deal with major reform. Now let me mention a couple of things that I hope in the context of this hearing, perhaps even more specifically in future hearings, I think are important to deal with. First of all, I have had a passion for the issue of price transparency. In the healthcare arena, it's one of the few areas that you just cannot know in advance of a service being rendered what the charge is going to be. And the reason is, and it indicates part of the problem we are wrestling with, is the reason you don't know is because the question is always followed with a question. When you ask how much is it going to cost, the question becomes, well, who's going to pay? And who pays depends on how much the cost really is. And that's something that you do not find in most other areas of service in our nation. So price transparency is an issue, and I'm pleased that the chairman and the chairman of the subcommittee have both indicated a willingness to explore that issue in the future. But let me talk about a couple of other things. I think you're going to find that throughout all of this, the issue of medical malpractice reform has got to be one of those issues that we just simply cannot ignore. Now, it manifests itself not only in private physician and hospitals practices, but also the one that is probably the most acute that we tried to deal with several years ago, and that is the emergency rooms. With EMTALA required to treat everyone, with no ability to divert without running the risk of being held accountable on a liability basis, you're just simply going to continue to see, as in my local emergency room, the primary reason for presentation is ear infections. And you probably could duplicate that all across the country. Non-emergencies being presented in the most costly environment, that is an emergency room. But until we deal with the ability either to alter EMTALA, which I have no confidence that that will be done, or to provide some protections, as we attempted to do several years ago, for diversions to non-emergency settings in an environment close to the emergency room so as to take that pressure off and the financial as otherwise the pressure off, I think we still have a problem there. Now, there are other issues, and I'm just going to deal with them in very broad, general things. First of all, I think we have to remember that as we're dealing with an expansion of government power, we never can forget about the fact that the only thing that keeps our country working in almost every facet of life is the issue of personal responsibility. When we have government assuming all of the responsibility, then it is very difficult to get people to do what they need to do for themselves, not only financially contributing to the cost of their health care, but to doing the things that they need to do that the chairman has alluded to, such as prevention, such as wellness programs, et cetera. A few other things that I'd like to mention. I think that as we deal with the broader context of how to reform the delivery system, hopefully we will not forget the private sector. The private sector has been the primary mechanism for providing health insurance through the employer-based system. Obviously, it has some problems. I would like to see us be able to take advantage of the one that has the most personal responsibility, and that is a medical savings account where a person has the right to decide how they want to spend their money, and they're directly involved. But they can't be the ones that are paying the highest price. If that's the case, then you can't make that kind of system work. Thank you, Mr. Chairman. This is certainly the beginning, I hope, of a wide-ranging look at the issue of health care reform, and thank you for hosting this hearing today. I yield back.
Thank you, Mr. Deal. I'm going to recognize our chairman, Mr. Waxman, but let me just digress a minute here, if you'll bear with me. There are a lot of people on this committee who have played major roles over the years in the health care debate, and if we do actually accomplish health care reform in a significant way this year, I think that we owe a lot to them, and Mr. Waxman, Mr. Dingell, others are amongst them. And I just wanted to say, you know, I remember 20 years ago, because this is my 20th year, I came to this room and I watched Mr. Waxman and Mr. Dingell and others talk about health care issues, and I was so impressed. That's why I wanted to be on this committee. And I know that's why a lot of the new members have started. We have a number of new members on our health subcommittee this year, and they've expressed the same thing to me, that the main reason they came to this committee was because they wanted to deal with health care reform. But if and when we accomplish this goal this year, a lot of the credit is going to go to some of these people who have labored for years on this issue and brought out a lot of the problems and solutions that are necessary for health care reform. And certainly our chairman is the leader, or one of the leaders amongst them. So I just wanted you to know that, Henry.
Thank you very much, Mr. Chairman. And when we accomplish the goal of enacting health insurance, affordable health insurance for all Americans, you will be there ranking among all the members who have played a significant role. This isn't one or two. It's all of us working together. And I thank you for holding this hearing on the health reform issue. I think we have a unique opportunity. President Obama has called on Congress to work with him to enact comprehensive health reform this year. And to underscore his commitment, the President has proposed over $630 billion in new revenues and program savings to help pay reform. This marks a sea change from the last 8 years, and as we'll hear from our witnesses today, it comes none too soon. The status quo is simply no longer an option. The health of our people, the health of our economy depends on achieving affordable, high-quality, sustainable coverage for all Americans. The President has laid out the broad outlines of his preferred way to achieve this goal, and I think his approach is sensible. It builds on and protects the employer-based coverage that's now in place for most Americans. It lets those people who have coverage that works for them keep that coverage. It strengthens the safety net of our vital public programs, Medicare, Medicaid, CHIP. It gives people a place to go to get accessible, affordable, high-quality coverage through private plans, or if they prefer, through a public alternative. The choice is theirs. And it recognizes the critical importance of prevention and wellness services and the management of chronic diseases. I'm determined to work to find the approach that will be broadly acceptable to the American people, to the providers that are critical to making it work, and to the members of Congress who in the end have to pass it. This hearing begins the work of this committee in responding to the President's request. As the testimony will make clear, the health care challenges we face are daunting, and finding workable and enactable solutions will be extremely difficult. Mr. Chairman, you as chairman of the subcommittee will build on the work that I and Mr. Dingell and others have done over the years, and you and the newer members of the committee will bring a vitality to this effort that I think will finally get us to the goal that has been so elusive. And I look forward to working with you on this in this regard.
Thank you, Mr. Chairman. Next is our ranking member of the full committee, the gentleman from Texas, Mr. Barton.
Thank you, Mr. Chairman, and I want to commend you and full committee Chairman Waxman for the bipartisanship in arranging these series of hearings. This is not like the hearing upstairs on climate change, where there is a clear ideological difference, and we have even gotten to the point of arguing over how many witnesses and which witness and this type of thing. In this subcommittee, under your leadership and Mr. Waxman's leadership, it's been a very cordial operating relationship, and I do sincerely want to commend you and Mr. Waxman for that. Health care is very important to everybody in America, and I do slightly disagree with your opening statement, Mr. Chairman, when you said that you used to think the United States had the best health care system in the world, but you don't think we do anymore. I think we still do. I think our health care system is the best in the world. I think it's the best in terms of quality. I think it's the best in terms of inclusiveness. I think it's the best in terms of its research capability. I do think there are problems with it. I think that obviously Americans that don't have health insurance are not able to take advantage of some of the wellness programs and the preventive medicine practices that are becoming more and more prevalent. But if somebody in America is sick today and needs to see a doctor or a health care practitioner, they're going to see them. Whether it's in an emergency room or a clinic or a private doctor's office, they're going to see them. And the more serious the condition, the more fortunate that person is that they're in the United States of America. My sister-in-law has just undergone 6 weeks of chemotherapy treatment at MD Anderson in Houston, Texas. She went home Sunday to recuperate. Her CAT scan and the tests that they run show that the cancer that is ravaging her body is beginning to recede because of the treatment that she is receiving and hopefully will continue to receive after her body recuperates. I'm darn glad that she lives in the United States of America, and I'm very glad that she lives close enough to MD Anderson in Houston, Texas, that she could take advantage of the treatment that's available there. People come from all over the world to that facility for that type of treatment. So what we're engaged here today, Mr. Chairman, is to begin a discussion of how we can improve our health care system. And I think we can do it. I do think our health care system is too expensive. I do think that there are lots of ways that we can improve it. I agree with you that the President's health care meeting at the White House last week was very productive. I said there, and I'll say here, I agree with President Obama's 8 principles. But the devil is in the details, and that's what these hearings are going to accomplish. I think there is a difference between Republicans and Democrats. In general, I think the Democrats, the majority party right now, want more government involvement in health care. I think Republicans in general would rather have the private sector and a marketplace system with openness and transparency where doctors and patients make the decisions themselves and don't have to depend on some sort of a government official or a government program. But I do think the government needs to be involved, and I think that somewhere in these hearings perhaps we can have a meeting of the minds. So, Mr. Chairman, I am involved in the health care debate in this committee in a different way than I am the climate change hearing issue. I think on health care, we can improve the system, and we can find a consensus, and we can do something hopefully this year to make health care for Americans more affordable and more accessible and even higher quality than it is. I must say on climate change that I'm hopeful that we can convince enough people that's not something that we need to do given the state of our economy. In any event, this is a very good hearing. You've got good witnesses, and I look forward to a serious discussion.
Thank you. I'm going to thank our ranking member. Next is our Chairman Emeritus, and I cannot have enough accolades about his involvement over the years in health care reform and Medicare, and again, look to him as one of the giants on this issue. Mr. Dingell.
Mr. Chairman, I thank you for those kind words, and I thank you for holding this hearing, which is a very important one, about designing a high-performance healthcare system. We have a splendid healthcare system in this country which doesn't work. It doesn't work because we have 47 million Americans who lack care, and we have a lot who have substantial deficiencies in the amount of care available to them. We have a worse situation in that the problem is fixable, but it has not been able to be addressed for years because of intense lobbying by the health insurance lobby and others. I remember we lost it the last time by 1 vote here. And we lost it in good part because of dawdling by the administration, which made a fine speech on the subject on the floor of the House in February and didn't present the bill to the House until sometime in November, by which time we had lost in this committee and in a meeting of the Business Roundtable by 1 vote. The health care system in this country is wonderful, but it doesn't work. And one of the problems about it is that we're seeing large numbers of Americans die prematurely or suffer from serious health problems because of the lack of availability of care from this extraordinarily advanced system which we are blessed with. Health care costs are far higher in the United States than in any other advanced nation. These costs have been rising significantly faster than the overall economy or personal incomes for more than 40 years, and if left unchecked, will shortly create irreparable harm to the nation's health and economic system. The 2 curves which are important to us in this country, the GDP and the cost of health care, or the percentage of health care, will cross about 2070. That should give us a warning. We've heard the data. Health costs are consuming a growing share of federal and state government budgets. The United States spends $2.2 trillion and more on health care each year, about $8,000 per person. This represents 16% of the total economy and is expected to reach almost 20%, more than $4 trillion by the year 2017. Health insurance premiums have doubled over the past 8 years, raising 3.7 times faster than wages in the last 8 years. And American businesses are due to losing business share in world competition because of the increasing cost of health care for their employees. For example, a General Motors car today contains about $1,600 in health care costs per car. General Motors is in fact not an automobile producer, but a health care provider that makes automobiles to pay for the cost of it. And the same is true for many other U.S. corporations. American automakers spend more now on health care than steel. They only spend $750 on steel. And Starbucks spends more on health care than they do on coffee beans. No one can dispute the fact that we spend a great deal of money on health care. America enjoys the most outstanding cadre of healthcare professionals on the planet, the most advanced technologies, the most innovative healthcare institutions, and the finest medical research, which is a model for the whole world. However, in spite of this great investment and the amazing talent of our health workforce, our health system continues to operate at low performance, and more spending has not and does not mean better quality service and care available to the American people. Studies have shown the United States underperforms relative to other countries on most dimensions of healthcare performance. It has lower life expectancy and higher infant mortality, amongst other things. But there's plenty of other things wrong if you will read the statistics. A number of other studies have shown that many surgeries are performed without being clinically appropriate. Patients typically receive about half the recommended treatment and services. About 100,000 Americans die from medical errors in hospitals every year. Half of these cases are avoidable. One quarter of medical spending goes to administrative and overhead costs, something which we must address if we're to save ourselves from a crazy system that is failing. Across the nation, healthcare costs vary substantially, however, and higher cost areas, surprisingly, do not generate better health outcomes. Our goal of providing health care securities for those struggling to keep the coverage they currently have while expanding coverage to the 47 million Americans currently without coverage is clearly necessary. However, we must all do what we can to first make our current system of health care more efficient and effective, including the care provided by public programs like Medicare and Medicaid, the cost of which without reform will become unsustainable in the near future. The current payment structure of these systems do not encourage coordinated care and encourage unnecessary treatment, which in turn leads to higher costs and significant inefficiencies. I look forward to the testimony of our witnesses today and to continuing our discussion and action as we seek to reform our health care system. Mr. Chairman, this has long been a passion of mine, as you have noted, and also of my great father, who introduced the first legislation on this in 1943. I look forward to working with you and with Chairman Waxman and the others of my colleagues on both sides of the aisle to solve this terrifying problem. Thank you, Mr. Chairman.
Thank you, Chairman Dingell. Next, we have the gentleman from Kentucky, Mr. Whitfield.
Chairman Pallone, thank you very much, and for this hearing on making health care work for American families. We all hear a lot about health care reform, and we know that there are basically two reasons that we're moving down this avenue. One, health care costs continue to escalate, health insurance premiums go up, and then access for all of the American people. And I noticed that President Obama in his budget has set aside $634 billion for health care reform. And although his plan is quite sketchy, the one thing that he has talked about specifically is a federal board to set provider rates, design coverage, and ultimately control prices in the health care market. I think from a philosophical point of view, healthcare reform gets down to a debate on both sides of the aisle. When we talk about these federal health boards, most of us, I think of Canada and Great Britain. They both have federal boards. And the key issue, at least from my understanding, is that in both of those countries, while the primary health care delivery system is very good, they basically rationalize health care, and that's something that we've really never done in America, so that if you do not meet a certain criteria, then you're not going to be eligible for a particular kind of health care procedure. That's something I think we have to move very carefully with as we discuss health care reform. A second thing, it looks like to me that I philosophically believe that a federal board is not the way to go. Because when you talk about an effective health care system, I like to look at Part D of the prescription drug benefit under Medicare. Because today we know that the premium for that plan is less than what was originally anticipated. The cost of that plan is less than what was originally anticipated. And the reason for that, in my view, is that in every jurisdiction, you had private companies coming together, competing with each other, offering plans. And more important than the cost is that the senior citizens seem to be satisfied with their Part D prescription drug benefit. I know that not all of them are, but generally speaking, they're satisfied. And I think that is a model that, as we talk about health care reform, that we definitely need to explore, giving patients more of an opportunity to decide for themselves rather than a federal board making all these decisions. And I'll yield back and balance my time.
Thank you. Next for an opening statement is the gentlewoman from Colorado. The gentlewoman from Colorado, and thank you again for your work on stem cell.
Thank you very much, Mr. Chairman. It was a banner day yesterday. I was just telling Congresswoman Capps about my sister, and I think I'm going to talk about that because it's why we have to do something about health care in this country. My sister is married to a fellow who has worked for one of the local school districts for many, many years, and she's a stay-at-home mom. She homeschools her kids, and they're middle-class Americans. Their insurance premiums working for the school district are $1,100 per month with co-pays and exclusions and everything else you could imagine. And about a year ago, my nephew, as teenage boys will, was skateboarding and broke his arm at the skateboard park, and his friend's parents couldn't find my sister to ask what to do. It was a compound fracture with the bone sticking out. So they took him over to the local emergency room, and then her insurance company refused to pay the bill because they said they didn't get pre-approval. And that's what kind of health care system we're living in this country, and that's why we need to have comprehensive national health care policy. And that's why, Mr. Chairman, I'm so grateful to you and also Mr. Dingell and also the President for pushing this through. We've got to do something about a system where we're spending over $2 trillion a year, but our health outcomes are abysmal. I just want to reference really quickly two studies that we've seen recently. In 2007, the Commonwealth Fund did an international health care survey where they compared the American health care payment and service delivery system to 6 other countries and found huge disparities. For example, the United States spends $6,697 per capita on health care services, which is more than double the per capita expenditures of all the other countries. Canada was the next highest, spending only $3,326 per capita. Well, you could say we have the best health outcomes in the world, which is what many people assume. However, this is simply not true if you look at the rest of the data. For example, the most recent data from the Centers for Disease Control ranks the U.S. 29th worldwide in terms of infant mortality, and it also ranks us 31st worldwide in terms of life expectancy and 24th in terms of women's health. The U.S. ranks 37th overall in the world for health outcomes, just below the Dominican Republic and Costa Rica, and just above Slovenia. So if anybody thinks that we don't need health care reform in this country, they not only need to look at these statistics, but the statistics that average American families, middle-class families, are dealing with every day. Thank you very much, Mr. Chairman.
Thank you. And next is the gentleman from Texas, Dr. Burgess.
Thank you, Mr. Chairman. I appreciate you holding this hearing as well. So much of what we discuss, I have an opening statement that I'll submit for the record. It's very thoughtful and well written. But let me just make a few comments because of what I've heard. We spend so much time talking about cost and coverage, and I do implore us to remember that health care is first, foremost, and always about taking care of people. I also urge us not to let the perfect become the enemy of the good. Now, we heard the President talk on Thursday of last week down at the White House at the forum that the only thing that was not acceptable is the status quo. Well, true, there are things we can make better and that we should strive to make better, but I promise you, having spent 6 years now in this body, I know we can make things worse, and we must be careful that we don't do that. I certainly don't want to diminish the contributions of any of the the men and women who work in the American healthcare system, because I know firsthand that they do day in and day out a tremendous job. Now, just a word about 1993, 1994. I was not here then. It is often talked about in healthcare policy circles as the failure to improve healthcare in this country, but I would just simply submit the world has not been static. The healthcare world in the United States has not been static since 1993, 1994. Indeed, some of the things that came out of the failure of the Clinton healthcare plan, certainly medical savings accounts were one of the things that came out about that. The state children's health insurance program was one of the things that came out after the failure of the Clinton's plan, and I would argue that these are good things. On the issue of medical savings accounts, the fast forward to the present time with what we've seen in the improvements with health savings accounts, just a personal story that I'll share with you. In 1994, I had an adult child who finished college and moved back home and chose not to go to work. I don't recommend that if anyone's considering that for themselves. Don't try this at home. But I could not get an insurance policy for any price. I was willing to write a large check for that insurance policy. Fast forward to today, and last Friday I went on the internet and looked under ehealthinsurance.com, and for what would be a comparable situation, a 25-year-old female, and I used the Washington, D.C. area code, actually you could purchase an HMO plan through Kaiser here in D.C., $98 a month, no $20 copay, but not a high deductible plan. In fact, there was no deductible. So there are options out there for people who don't find themselves without insurance that were not available in 1993 and 1994. So please let us not fool ourselves that the world has been static since then. Certainly, examples of how we can make things worse. Look what we did with the health information technology and the stimulus bill, and I tried to offer an amendment so that we could use these funds in June of this year, but instead it's June of 2011, and we have doctors' practices all over the country that have lifted the pen, literally lifted the pen off the check, and are going to wait an additional 2 years before they write that out. We must look at the things that are actually working today. Affordability does remain key in the equation, but let's look at the things that work and not just focus on trying to expand the things that don't. Certainly, employer-sponsored insurance, the price is increasing over 7% a year. Medicare and Medicaid, we know, increase at 7.4% a year. Consumer-directed health plans increase at 2.2% a year. Shouldn't we take a lesson from Safeway and Walmart and what they've been able to do with forward-leaning plans that they have implemented before we just simply provide a program essentially equivalent to Medicaid for all? And if we're going to do Medicaid for all, shouldn't we also do that for members of Congress? I introduced an amendment like that on the S-CHIP bill, and I got no votes in the Rules Committee for that. Dr. Zerhouni has come to this committee and talked about a time when medical care is going to become a great deal more personalized. He says because of the human genome, we're going to be a great deal more predictive. We can, as a consequence, be a great deal more preventive, and it is going to require us to be more participatory. That's the direction in which we need to be moving, not in a direction that's going to harm that forward progress that we've already made. And, Mr. Chairman, you've been generous with your time, and I'll yield back.
Thank you. Next for an opening statement is Ms. Capps. Let me mention that once again she is the vice chair of this subcommittee, and deservedly so, since she's done so much work on health care, particularly on health care professionals.
Thank you, Mr. Chairman. I'm so pleased we are beginning our hearings in this Congress on health reform. It is clearly, in my opinion, the #1 issue this subcommittee needs to address. And as the President has articulated in his health summit and so many other places, our efforts at overhauling our nation's broken health system are really integral to our work in improving the economy. I'm eager to hear from today's witnesses about how we arrived at this point in the first place. Why does the United States, and we've heard a lot of documentation in the opening statement so far, with all of our innovation and our spending, why do we measure up so poorly against other industrialized nations? Why do we have such high infant and maternal mortality rates? Why do we have a lower life expectancy? Why do we pay so much more but receive so much less? Our next steps, of course, are how to address these factors that plague our healthcare system. I'm counting on a certain absolute, that in any solution we offer or pursue, we should bring and will bring prevention and wellness back into the fold as a core ideal. During the Bush administration particularly, there was very little attention given to the importance of prevention in health care. And because of that, our nation's public health infrastructure has suffered. We need a system that incentivizes primary and preventive care, not one that simply responds to chronic diseases and emergencies, often in the emergency room. We need a system that invests in our health workforce so that enough nurses, physicians, and a myriad of other professionals are available to treat people and to work with them. Not one that divests from medical and nursing education or cuts reimbursements. I'm glad to see this issue is on the agenda for future hearings. In closing, I just want to underscore the urgency with which we must address the current crisis. It is very real today in the communities we represent, in communities across this nation, in rural areas, and in the inner cities. And I very much look forward to hearing what our witnesses are saying today, and I yield back.
Thank you, Ms. Capps. And next, for an opening statement, another one of our healthcare professionals, which we have quite a few on this subcommittee, the gentleman from Georgia, Mr. Gingrey.
Well, Mr. Chairman, I thank you, and I want to thank, of course, overall committee chairman Waxman and former chairman Dingell, our ranking member Joe Barton, and the ranking member on this health subcommittee, my colleague from Georgia, Congressman Nathan Deal. I also want to thank Dr. Todd Williamson from great state of Georgia, who is chairman of the Medical Association of Georgia, neurologist, a practicing physician from Lawrenceville, Georgia. Like my colleague from Texas, Mr. Chairman, I have a statement, too, that is fantastically written, and I want to just submit that for the record, but I actually didn't write it. My staff wrote it, and I want to give them all due credit, but I would like to ask unanimous consent to submit my written statement for the record, and I'll just make a few off-the-cuff comments. I agree with the President. I agree with the Democratic majority and many of my Republican colleagues that we need to do something, that health care in this country, while I believe is the best in the world, at the same time, I think that we have the best of times and the worst of times. And that is to say that while what we are doing with medical care in this country, I believe is the best in the world, the reason the statistics are so bad, as Ms. DeJette and others have mentioned, is the fact that we have 47 million people who don't have access to affordable coverage. And we have too many underinsured. And as a result of that, they put off getting needed care, going to the emergency room, going to their doctor. The availability is there, but they don't have the money, so they wait until things are so bad that it's really costly. And that's why it's the best of times and the worst of times. I think we need to look very closely, though, at what we can do to make sure that we improve our system. There is so much room for improvement. My thoughts have always been that if there's a real emergency to get something done by August the 1st of this year, even when our economy is suffering tremendously and we're trying to get that back on track, then maybe the money that we're spending, the $19 billion on having a fully integrated, comprehensive electronic medical record system is a direction in which we need to go, as well as a liability reform, which we have needed since California did it way back in the late 1970s. So there are many things, Mr. Chairman, that we can do. I think mainly, as I close my remarks, I just want to say that we don't want to destroy the marketplace, and we don't want to destroy the doctor-patient relationship, which is so important if we are going to continue to get the brightest and the best young people to go into this wonderful profession. And I'll yield back at this time, Mr. Chairman.
Thank you. Next, recognized for an opening statement, the gentleman from Texas, Mr. Gonzalez. Thank you. And next, gentleman from Pennsylvania, Mr. Murphy.
Thank you, Mr. Chairman, and thank you for doing another hearing on what we need to do with health care reform. I want to bring attention to an aspect here which I still hope that somewhere in this federal government we'll deal with, and that has to do with waste and inefficiency and its additional costs in this whole system here. We have and I do believe we have a great system of health care. I also believe that, unfortunately, sadly enough, we waste a lot of money in this whole system, and that leads to a lot of deaths. Let me just raise a few issues here, and here I also want to credit Dr. Gawande, who's here. There you are. Okay, I couldn't see you behind her before. Thank you for this great article in the New Yorker. I hope I'm here later when you testify, but you point out a couple of things we need to pay attention to, and that is that there's a lot of money and a great many lives we can save by practicing health care, and along these lines, making sure government supports the doctor-patient relationships and doesn't get in the way. We look at statistics such as 90 to 100,000 deaths each year from infection, costs $50 to $52 billion. Programs like the Keystone Initiatives have been able to save a lot of lives and save a lot of money, which helps make health care more affordable. Using these numbers, so far this year, there's been 378,082 cases up to this moment, to this hearing, 18,713 deaths, and a cost of $9,452 million. These are unacceptable. And as long as we continue to talk about quality, affordable, accessible health care, we have got to deal with these issues of true quality. But the list goes on and on. The underuse of appropriate medication, such as generic hypertensives, could save us another $3 billion a year if that was corrected. The underuse of medications for pediatric asthma could save us another $2.5 billion. One of the things that the government did in its infinite wisdom is said that the aerosol for asthma should no longer contain air that affects the ozone. So that was removed. New substances were put in that made the asthma medications brand name, raised the prices, and I don't know what that's done in terms of increasing admissions to hospitals since those studies have been reported. The overuse of medications such as antibiotics adds $8 billion to the cost. You also have to deal with untreated complications that come from mental illness that's associated with chronic illness. And yet what's happening in situations like this, we need programs that do real case and disease management to look at what kind of complications and problems are coming from underuse of medications, overuse of medications, referrals that are not needed, treatments that are needed. But instead we're talking about cutting programs like Medicare Advantage without looking at what Medicare Advantage does. To the extent that it works on prevention, disease management, and wellness programs, I hope this committee reviews what can be done in assisting those things. But this idea of saying that what we ought to do is just look at universal health care without looking at what we're doing for health care has got to stop. Along those lines, Mr. Chairman, a report came out in the last couple of weeks from the New England Healthcare Institute called Waste and Inefficiency in the U.S. Healthcare System, Clinical Care Comprehensive Analysis in Support of System-Wide Improvements. This report says that in our $2.3 trillion healthcare system, we have between $600 and $800 billion of waste that's hurting people, that if we remove this, it doesn't hurt healthcare, it actually improves healthcare. And that certainly helps meet our goal of affordable, accessible, quality healthcare. Mr. Chairman, I'd like to submit this to you and hope this is something that members of the committee would have at their access and perhaps include this in the record. It's a review of a lot of studies and the kind of things we should be looking at. I end with this. I've known a number of people who have been hurt and harmed in hospitals, and we don't usually do this, but I'm just curious. We have a good-sized audience out here. How many people here know of someone who went into a hospital or clinic and ended up getting an infection that made it worse? Raise your hand. I submit for the record, Mr. Chairman, there's a lot of lives we could be saving out here if we took efforts on this. I yield back.
I thought that we were going to have like we did with the other day with Mr. Boyer, and you were going to get up with the chart, and I was going to feel like I was in a classroom again. But thank you. As I mentioned, we have quite a few health professionals. Mr. Murphy is a psychologist, and now we have our colleague from the Virgin Islands who's also a physician, Ms. Christensen.
Thank you, Mr. Chairman, and thank you, Chairman Pallone and Ranking Member Deal, for bringing the subcommittee into the healthcare reform process early and planning the series of hearings that we're going to have so that we can fulfill our responsibility on this vital issue. And although I'm not practicing medicine today, I'm always going to be a physician, so I come to this from the same perspective of Dr. Williamson and others that I've heard speak to this today, Physicians, though too often blamed, are not the cause of the problem, but restoring the integrity of the physician-patient relationship can be a part of the solution, and I hope it will be. I put the blame largely, it rests with the reimbursement system and the failure of our country to provide universal coverage. But fixing this country's system of non-healthcare delivery and making it work for families will require far more than providing coverage. It must include addressing and ending our long history of unequal access to healthcare for racial and ethnic minorities, for women, for families in rural areas, for gay, lesbian, and transgender communities, and anyone perceived as different or who speaks differently or who's far enough away to be ignored, such as those of us who live in the territories. I've had a chance to look at some of the testimonies, and I just want to make some comments. Mr. Levine, I support increasing and expanding Medicaid, but I do share some of your concerns about Medicaid because increased access has not always resulted in better health outcomes. But I think that this is due in part to assumptions that discriminate against women, against people of color, and the poor. And that's why aggressively moving to increase providers of diverse backgrounds at all levels of our healthcare system has to be a part of designing a high-performance healthcare system. Mr. Hackbarth, the Commission has a heavy responsibility because so many important policy decisions rely on your recommendations, and I hope that you'll be able to assure me that the territories will receive equity in those recommendations. Dr. Gawande, I've really been impressed with not only your testimony, but what I've heard and read from you in the past. I'm concerned, though, that you don't reference the issue of disproportionate burden of disease borne by people of color and rural Americans in your testimony, or address the elimination of health disparities in your recommendations. Director Elmendorf, you are part of our congressional family, and I look forward to working with you, especially because I think we have a little work to do to convince you on the savings that really will be realized from universal coverage and prevention. So I look forward to that. And lastly, Mr. Ebler, I thank you for all of the work that the IOM has done on the issue of the uninsured. The Institute has clearly shown that this is not just a problem of those so unfortunate as not to have coverage, but it's a problem that increases the cost and undermines care for everyone. All of the vulnerabilities you list speak directly to health disparities, which must be a central focus as we work on healthcare reform if it's to be successful. So I look forward to all of the oral testimony and the dialogue that will follow, and I thank all of you for being here this morning.
Thank you. Next is the gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman. I thank you for the hearing, and I, along with my colleagues, am looking forward to a discussion of how we reform the healthcare system and what route we're going to travel here. Now, there are some who would like to see it move toward a government-run entity. And coming from Tennessee, where we have had the TennCare experience, and many would argue that the TennCare delivery system is probably the most broken healthcare delivery system in the nation, and that it is evidence, or should be of evidence to us, that a government-run system will encourage cost overruns, mismanagement, inadequate service, rationing or elimination or diminishment of care in certain areas of the state. And also, it has become evident from the TennCare experience that the estimated savings or the projected savings, the expected savings, were not evident because of increased usage and the other problems that I've previously mentioned. Rather than encouraging expansion of inefficient and ineffective government bureaucracy for a healthcare delivery system, I feel that we should be putting our time and energy focusing on how to foster competition, how we would actually reduce cost and provide choices for patients and consumers. I do believe in consumer-driven healthcare, which empowers patients to make the best choices for their individual needs. and to do that with a physician and also as they are choosing an insurance product that best suits them. And the medical savings accounts were mentioned earlier by Dr. Burgess and the impact that they have had. Transformation to consumer-driven healthcare and putting our focus there would create consumer demand for information on prices, on quality. It would also shift us toward greater transparency, which other of my colleagues have mentioned is a need that we have for the healthcare delivery system. Our constituents are telling us they would like to have access to information about quality, about outcomes, testing procedures, so that they can be an informed consumer. Mr. Dill had mentioned the need for medical liability reform. I associate myself with his remarks there, and as I welcome our witnesses today, we look forward to a robust debate and for continuing the hearings, Mr. Chairman, that you'll continue to have on this issue, and I yield back.
Thank you, Ms. Blackburn. Next is the gentlewoman from California, Ms. Eshoo.
Thank you, Mr. Chairman, for holding this important hearing. We know it's important just looking at the first panel, the director of CBO and the chairman of MedPAC, and of course to be followed by the other witnesses. I think that this is really the easy part, is having the hearings. But the hearings are really the foundation for what we will come to do, and that is to reform our nation's healthcare system. I've been on this subcommittee for, this is my, I believe, 15th year. And what I've seen over the years are stops and starts. We've gone body part by body part to try and improve different parts of the system. Been successful in doing some of them. We have, I think, the world's finest doctors. I think we have the most innovative medical centers. We've progressed in leaps and bounds in biotechnology and the life science technologies. But our means of delivering care to patients is really inefficient. And it's costly, and it's often really counterproductive to maintaining good health. And this is now not only an issue for every American, and the American people are ahead of us on this. This is front and center an economic issue. The costs of our healthcare system in the country is just absolutely killing us. You know, we've increased at a rate that's double that of inflation, and that really should take everyone's breath away. So obviously, we need to reform. But I'm very mindful that this isn't called the healthcare industry for nothing. There are tens and maybe hundreds of thousands of players in this, stakeholders, and so we have a ways to go. But as the President said, in good times we didn't do it, in recession we didn't do it, after wars we didn't do it, now's the time to do it. I don't think we can afford to keep going this way, and I think the Congress will work its will. I think that there are going to be a lot of very good ideas placed on the table. Some will be somewhat startling because they will take down some of the old systems and bring about new ones. I'm open to all of those ideas, and I think that it is important for all of us to do that. And I don't think this is going to be done just by one party. We're going to really have to work together to get this done for the American people. So I look forward to it. And maybe this will be, I have confidence, I'm not going to say maybe, that in my 15th year on the committee, that we will get this done. So I welcome all the experts. We need the best ideas from the brightest and the best in our country. And I think that America is up for this. In fact, I think it's a demand of the American people that we do so. And when we do, I think that the rest of the world will watch and learn from us, because what America does is always a great lesson for the rest of the world. So thank you, Mr. Chairman, for the kickoff on this, and I look forward to the rest of it.
Thank you. Gentleman from Arizona, Mr. Shadegg.
Thank you, Mr. Chairman, and I want to thank you for holding this hearing. I want to jump off on the title. Making health care work for American families is the first part of the title, and I think that is essential. I think this Congress can no longer tolerate the problems with the current system, and therefore it must be reformed. The second half of the title is designing a high-performance health care system, and I believe we can do that, but I believe we have to do that by beginning with an analysis of what's wrong with the current system. As the gentlelady just mentioned, one of the things that's wrong with the current system is that costs have spun out of control. It's not exactly difficult to figure out why costs have spun out of control. We do not have a system in America that rewards the efficient delivery of health care. We have a system that rewards the inefficient system of health care. What we have is a third-party control system where your employer picks out your health care plan and your health care plan picks out your doctor. I suggested to a colleague this morning that would make about as much sense as if he said to me, okay, for the rest of my life, you, John, will pick out my homes, pick out my cars, pick out my suits, and pick out my shoes, and pick out everything else, pick out the food I eat, and I'll give those decisions to you. I suggest that if he gave those decisions to me and I tried my best to make him happy, I wouldn't make him happy. We've created a system in health care in America where we have divorced the consumer of the health good from the person paying or selecting that good. Right now, that system is a third-party control system where the employers pick the health care plan for their employees. Employees don't pick their own health care plan, and we've biased the system to say the only economic system that works is employer care. And oh, by the way, if your employer doesn't provide you care, we're going to encourage you to buy care, but we're going to punish you by saying that under the tax code you've got to pay a third more for that health care than your employer does if he buys it. So we've rewarded a system that gives the decision to somebody other than you to select your health care. And then we wonder why Americans aren't fit, why they don't eat right, why they don't control their blood pressure, why they don't control their cholesterol. I think if we look at the flaws in the current system, then it's easy to understand where we should go. We should not go to another third-party control. It seems to me it makes no sense to take third-party control by employers and plans and give that third-party control to the government. I got a flash. If I said to the government, you buy my cars in the future, you buy my house in the future, you buy my suits and my shirts, and you pick out the food I eat, the government wouldn't do any better job at making those decisions for me than my employer is. So what is the option? The option is, in fact, universal health care. This country has decided that nobody should go without health care, but we can give every single American health care and at the same time preserve choice. How do you do that? Well, you let the people that have the financial means to buy their own health care, buy their own health care, and you give them a tax credit to do that, and you say, go buy your own health care. But for every other American, you say to them, we're going to give you a stipend, we're going to give you a chunk of money, and you go make choices about your own health care. You buy a plan that meets you. Now, what about some person who doesn't respond and doesn't take up that plan? We put them in a pool and we say to them, if you need health care and you show up at a doctor's office, we're going to give you the health care. That way we've preserved choice. We've preserved people and consumers to make their own individual choices about health care. That will both bring down cost and bring up quality, and it's a system we can implement and will cover every single American. And I hope when we begin to design a system for health care in America, we look at the President's 8 points. I think every single one of those fits with what I've just described, and I believe we can do it, and we can do it for every single American. And I thank the gentleman and yield back the time I don't have.
Thank you. The gentleman from Maryland, Mr. Sarbanes.
Thank you very much, Mr. Chairman. And I want to congratulate you on now launching this discussion on health care reform, much needed, and looking forward to the various panels that we see. If and when, as Congresswoman Schakowsky said, we achieve health care reform, it'll only be partly because of the arrival of some of the newer members in recent years. It'll be mostly because of the incredible work that you and others, Chairman Waxman, Chairman Dingell, and other distinguished members of this committee have performed for so many years. It's a great committee with a great challenge before it. The broken healthcare system that we're all alluding to is one that really has two sets of victims. I had the privilege of working for almost 18 years as a lawyer with hospitals and physicians and clinics and nurses and other providers. And I say privilege because I've never witnessed the level of professionalism that I have when it comes to people that work so hard in our healthcare industry every day on the provider side. And they're one of the victims. They're one of the sets of victims here in this broken healthcare system because they're carrying it on their back right now. The other set of victims, of course, are patients and the consumers of healthcare. And, you know, most Americans don't really have any idea what the perfect design or even close to good design of our healthcare system will be. But for millions of Americans who are uninsured and underinsured, what they do know is that they get up every morning and they can't breathe. They are burdened by a corrosive anxiety that eats away at their self-dignity and eats away at the stability of their families. And that's why we've got to get this done. And I look forward to the hearings that are coming forward, and I look forward to getting health care reform done in a timely fashion. I yield back. Thank you.
Thank you. The gentleman from Pennsylvania, Mr. Pitts. Gentleman waves. Gentleman from Ohio, Mr. Braley.
I was confused by the reference to Ohio, but I will be glad to.
Did I say Ohio? I meant Iowa. I apologize.
Thank you, Mr. Chairman, and thank you for holding this important hearing. I'm looking forward, like many of the other members of the panel, to helping this subcommittee address health care reform over the coming months. But as we look at ways to design a high-performance health care system, I want to draw everyone's attention to two issues that directly impact the overall performance of this system. One, geographic inequity in Medicare reimbursement, and two, the considerable variation in health care quality across this country. The current system that we have in place has built-in inequities that result in the lack of access to care for residents in many rural states like Iowa. An example of this can be found in the Geographic Practice Cost Indices, or GPCIs. These antiquated figures ensure that some parts of the country receive drastically lower Medicare reimbursement rates than other parts and have led to a tremendous shortage of health care providers in certain parts of the country. In an attempt to achieve some leveling of geographic inequity in physician reimbursements, the Medicare Modernization Act of 2003 established a temporary floor of 1.0 for the work GPCI, which helps level the playing field for physicians in Iowa and other rural states. Congress has had to extend this floor repeatedly, yet the floor on the work GPCI still does not go far enough. Despite the well-documented deficiencies of Iowa's health care system, Iowa health care providers still lose millions of dollars because they choose to care for Medicare patients. Last Congress, I introduced the Medicare Equity and Accessibility Act, which addresses the GPCI problems. I will continue fighting for a permanent work GPCI floor as well as a practice expense GPCI floor, but frankly, this is only a Band-Aid for a broader problem. While Iowa's access to care ranks low, the state's quality of care consistently ranks right at the top. Iowa physicians, hospitals, and healthcare personnel are unrivaled and are a primary reason why Iowa consistently ranks in the top 10 healthiest states. Unfortunately, the way our current health reimbursement system is set up, it is not based on the quality of care provided, but instead incentivizes quantity of care, which results in considerable variation in quality around the country. I hope this committee takes a serious look at proposals to incentivize quality and efficiency, such as value-based purchasing models. This fundamental shift in our reimbursement system would lead to a tremendous improvement in the quality of American health care. Instead of a business model that encourages physicians and hospitals to get patients in and out as quickly as possible, we'd have a system that encourages them to make sure the patient is healthy. That's what really matters. By including efficiency measures and value-based payment programs, we can keep costs down for our patients in our federal payment programs. By aligning incentives across hospitals, programs, and physicians, we can achieve greater interoperability. And by encouraging care coordination, such as through the medical home concept, we can further deliver better and more efficient health care. So I want to thank you, Mr. Chairman, for tackling the important issue of health care reform, and I want to thank all the witnesses for spending time with us today.
I thank the gentleman from Iowa. And next is the gentleman from Michigan, Mr. Rogers.
Mr. Chairman, I'll submit my statement for the record in lieu of questioning time.
Thank you. Next is the gentlewoman from Illinois, Ms. Schakowsky.
Thank you, Mr. Chairman. In some ways, I think I've been waiting for this hearing all of my adult life. As my goal as a public official, I will die a happy woman if it says on my tombstone or urn or whatever they do with me, that she helped bring health care to all Americans. And I think this is the first of a process that I hope moves rather speedily. The President has targeted actually signing the bill after the August recess, so we have a lot of work to do. I think it's a total embarrassment that the United States of America, the wealthiest country in the world, does not provide health care to all of its people like every other country in the industrialized world. It's a moral issue, it's an economic issue, and one that that may be controversial here in this body, but actually outside of this room and in the country, most Americans are ready for change, they're ready for big change, and they see an important role for government in that change. Anyone who thinks that we have good access to health care doesn't live in the real world. In my state alone, 1.8 million people have no health care, but that's just the beginning, the tip of the iceberg. The number of people who are uninsured, over half of Americans say that they have delayed health care or foregone health care because they can't afford it. As people lose their jobs, 650 people every day in Illinois right now losing their job, 14,000 people losing their health insurance every single day. This is a crisis that cannot wait to be solved. So I want to make one other point. There's been a lot said about having a public health insurance option, the choice, which 73% of Americans say they'd rather have a choice of a public option or a private option. If their private plan works for them, fine. But I would say it's the private health insurance industry that has some explaining to do. The Medicare is one of the people come into my office and say, I can't wait until I'm 65 years old. I am sick right now, and I'm looking forward to my 65th birthday so that I can actually get the health care that I need. And persons with disabilities and seniors have been lifted out of poverty because of this successful social insurance program along with Social Security. The Commonwealth Fund did a study and found that designing a health care system that covered everyone, including a public health insurance option, over 11 years would save $3 trillion to do that. In 2008, private market health insurance premiums rose by 5% to nearly $12,700 for a family of four, $4,700 for individual coverage, and so private insurance is increasingly out of the reach of Americans. And so what the President has proposed is to have this option of the public health insurance program or a private. I think that that ought to be a centerpiece of any plan that we adopt. And I yield back. Thank you.
Gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman, and I appreciate the time. And following my colleague from Illinois, I know your current senator was concerned about what was going to be on his tombstone. I would hope it would be, that's not in Illinois an issue. But I want to, like my colleague from Illinois, though, having moved to the Energy and Commerce Committee in '97, this is one of the most important hearings I think we can have because it's a start of on what we're going to do in this Congress to change how health care is provided in our country. I come from a state of Texas where we have the highest percentage of uninsured in the country, that have the highest number of uninsured in the country. There are a lot of reasons for that. And I'm glad the President also in his budget released a couple of weeks ago is planning to take action on health care. I also like the principles he laid out for us last Thursday. Instead of sending down a large piece of legislation where they try to dot all the I's and cross the T's, that's Congress's job, is to draft the legislation. Give us the goals, and we will do everything we can to get to it. Again, this is our first hearing on, we currently have 47 million people uninsured in our country, and overall health care is consuming ever-increasing amount of our resources. Health care expenditures are now 16% of GDP, with the rate going to maybe 20% by 2017. Unfortunately, we're paying more for the cost of health care, but seem to be receiving less and fewer people having access to quality and affordable health care. The current economic times make it even harder for individuals that are uninsured simply because their companies can't afford health premiums, or their employers can't afford, the companies can't afford health insurance, or their employees can't afford to pay their percentage of the premium. We recently passed the American Reinvestment and Recovery Act, which I strongly supported, and extended COBRA subsidies to individuals who lost their jobs, which is wonderful for those who had insurance before they lost their jobs. Unfortunately, in blue-collar districts like I represent, most individuals never have access to the health care in the first place because they are in low-wage jobs. Too many individuals in our country are unemployed or uninsured and are all too often end up in the emergency room with very costly medical issues that could have been averted with access to primary and preventative care. We can't continue to shore up a health care system with short-term fixes instead of long-term solutions. We cannot continue down the path in which is costly health care and more uninsured. I'm glad we're taking our first step in addressing the health care crisis, and I welcome our witnesses today to be the lead-off witnesses. And I have a saying in Houston, we have one of the greatest medical centers in the world, the Texas Medical Center. On a clear day in Houston, we can see the medical center, but most folks in my area can't get to it because they lack health care unless it's through our public hospital system. And with that, Mr. Chairman, I yield back my time.
Thank you. Gentleman from Ohio, Mr. Space.
Thank you, Mr. Chairman. I look forward to working with you as we begin this comprehensive debate on how we deliver health care in America. I think as we move forward, many of my colleagues have raised very important and legitimate issues. The health IT program, coordinated care, preventative measures, rewarding positive lifestyles, punishing negative lifestyles. But one element that I'm hoping we won't forget about is the importance of cure, curing disease. There has not been a significant breakthrough on a cure in this country since polio was cured. And cures are within our grasp. And not only do we have a moral obligation to alleviate or mitigate human suffering, cures end up being a very economically effective way of handling the healthcare crisis. In 2007, this nation spent $178 billion on one disease, diabetes. That's more money than we spent in Iraq. With a small percentage of those monies that were spent in that 1 year and that are spent every year at an increasing rate, we could cure the disease within 5 to 10 years, either naturally or artificially, providing every type 1 diabetic with a closed-loop artificial pancreas, mitigating and eliminating the expenditure of trillions of dollars over the next 30 years. That's one disease. Imagine what we could do if we invested in a cure for cancer, for heart disease, for liver failure, even for things like autism. We are, Mr. Chairman, I think, remiss in failing to address cures with an aggressive posture. And I'm hopeful that that will be a part of this debate as we move forward. In the end, I think we all share a common goal, and that is providing affordable access to quality health care. I don't care how we get there, but we have to get there. I yield back.
Thank you. The gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman. Addressing our health care crisis is the issue that brought me to public service in the first place. So I do want to truly thank you, Mr. Chairman, for holding this hearing and getting us started on this enormous task that's before us. And I want to thank all of our witnesses in advance because your expertise is going to be invaluable to us in the process. In a report released last week on the series of health care community discussions held around the country, the Department of Health and Human Services found that more than anything else, Americans want a system that is fair. No matter what your circumstance or background, the American health care system should perform well for you too. To that end, I will address briefly the three major issues that we all know so well: access, quality, and cost. As we will hear today, being shut out of the system is deadly. Uninsured adults are 25% more likely to die prematurely than insured adults. And if they have a serious chronic condition, the situation is worse. And every day, more and more people are falling into the ranks of the uninsured. Erosion of employer-based coverage and the challenges of the individual market demand our immediate attention. A high-performance healthcare system, by definition, must also deliver quality care. And I strongly believe that providers can use performance measurements to drive quality improvements. A leader in this respect is a hospital in my own district, the University of Wisconsin Hospital and Clinics. They have led the way in several nationwide efforts to benchmark performance. They consistently rank among the top 5 academic medical centers in the country according to 5 key metrics: mortality, effectiveness of care, safety, equity, and patient-centeredness. These efforts at public reporting and the sharing of best practices demand excellence from our healthcare system. Lastly, I want to quickly address the issue of cost. We are operating under an assumption today that at first glance seems implausible, that we can pay less for our health care and get more from it. And yet the data is clear. Our current system is wildly inefficient. Some of the highest cost regions produce poorer patient outcomes. Some of our lower cost regions produce some of the highest outcomes. I'd like to personally thank our witnesses on our first panel today for your invaluable assistance in helping us solve this problem. MedPAC has recommended significant restructuring of the payment system, suggesting that we pay for care that spans across provider groups and types and time in order to hold providers accountable. For me, health reform is an endeavor that is both intellectual and emotional. As a member of Congress, I know that we must control the unsustainable spending in our healthcare system. As a representative of the men, women, and children in the 2nd District of Wisconsin, I know we must fix our broken system so it can reach and serve everyone. Again, thank you to our witnesses today for being here, and Mr. Chairman, for beginning our work in earnest.
Thank you. The gentleman from Arkansas, Mr. Ross.
Thank you, Mr. Chairman, and like Dr. Burgess and so many others, I had a prepared statement that I'll submit for the record, but most of what I said in that has already been said. But I would like to speak for a moment from experience and from a rural perspective, if I may. I served for 10 years on the state health committee in Arkansas in the state Senate, and that is where I learned that any real reform had to happen at a national level, and it inspired me to run for Congress and to seek this committee and seek this subcommittee. I chair the Blue Dog Healthcare Task Force, and it's the rural perspective I took to the Healthcare Summit at the White House last week in our breakout session. My experiences as a pharmacy owner, someone married to a pharmacist, and being from a small town, I can tell you I've seen too many people walk through the doors of that pharmacy that could not afford a $30, $40, or $50 medication. And living in a small town, I would learn where they were in the hospital a week later, running up a much higher bill, if you will. We have got to make health care affordable and accessible and available for everyone. My hometown is much like my district. I represent 150 towns, and half my constituents don't live in any of them. They live down this gravel road or that gravel road, and it's important that those folks have access to health care too. My hometown is a good representation of my district. It's 3,600 people when I'm home, and 2 traffic lights. Just a few years ago, we had 6 doctors, 5 pharmacies, and a hospital. Today, we've got 3 doctors, 2 are over the age of 60, 2 pharmacies, and no hospital. The nearest hospital is in Hope, Arkansas, 16 miles away, and now it's struggling to keep its doors open. If it closes, we will be 40 miles from the nearest hospital. The leadership of the hospitals in Hot Springs, Arkansas, the largest town in my district, wanted to meet with me recently. And they wanted to tell me how Hot Springs cannot attract doctors. It's got a high retirement age population, a lot of sick folks, it's on a lake, and it's in a national park. By Arkansas standards, it is a prime place to live. And if we can't attract doctors there, what about these other 149 towns that are much smaller and much more rural? So I would ask that rural health care be an important part of any reform, and I can't help but think, Mr. Chairman, back to the days of Orrin Harris. His picture, his portrait's right here. He comes from my district. He chaired this committee. He began chairing this committee 5 years before I was born, and he was trying to reform health care then. That was 53 years ago. And I hope that we can get it done and get it done right this time. And with that, Mr. Chairman, I pledge to work with you. Please keep rural health care an important part of any reform debate. Thank you, and I yield back the balance of my time.
Thank you. The gentlewoman from Florida, Ms. Castor.
Thank you, Chairman Pallone, for this first in the series of hearings to reform health care in America and make it more affordable for businesses and families. You know, together with President Obama, we've already hit the ground running to improve the health care of Americans with the enactment of the landmark Children's Health Bill, the S-CHIP. The American Recovery and Reinvestment Act also provides much-needed assistance in COBRA, for COBRA payments for folks who have lost their jobs, and aid to states for Medicaid. We're not going to let our families fall through the safety net. Now, our larger challenge is to confront health care reform. And I believe we can tackle it with a commitment and determination to develop a quality, affordable health care options for Americans. In my home state of Florida, where we have the second highest rate of uninsured, families and businesses have been clamoring for access to affordable health care well in advance of the economic downturn and the rise in unemployment and home foreclosures. In Florida, it is estimated that more than 6 working-age Floridians die each day due to a lack of health insurance. The inability to afford basic health care poses a major threat not only to the well-being of families, but to our economy as a whole. Nearly half of home foreclosures in 2006 were caused, at least in part, by financial issues stemming from a medical problem. As President Obama noted just last week, the cost of health care now causes a bankruptcy in America every 30 seconds. Now, there will be many outstanding ideas, and I look forward to hearing from our witnesses. I believe particular focus and attention must be paid to the primary care system and preventative medicine. Also to the healthcare professions, especially this very arbitrary cap on physician resident slots that penalize states that have high growth and high population. Nursing shortages, Medicare reform. With everyone's help and my colleagues' expertise, I'm confident that we will reduce health care costs for families and businesses and hopefully our national budget. The time to act is now. I yield back my time.
Thank you. The gentlewoman from Ohio, Ms. Sutton.
Thank you, Mr. Chairman, for holding the first of many important hearings on health care reform. Health care reform is a critical component to our economic recovery and our nation's competitiveness. As health care costs rise, neither employers nor employees can afford them. And if one loses their job, the situation is even more daunting. I'd like to begin today talking about a family in my district, the Lee family. Mr. Lee has always had health insurance through his job, but when his company laid him off last year, he and his family lost coverage. Mrs. Lee tried to get coverage through her job, but she didn't qualify because she was a part-time employee. Now, having a family with medical problems ranging from diabetes to degenerative joint disease and being without health insurance has created a very, very difficult problem for the Lees. And unfortunately, Mr. Chairman, this is a situation that's familiar to far too many Americans. The Lee family is certainly not alone. In Ohio, there are over 1.2 million people without health insurance. And Mr. Chairman, this causes an amazing outcome. According to Families USA, 2 Ohioans die each day because they lack health care coverage. I want to say that again. In Ohio, 2 Ohioans die each day because they lack health care coverage. Many Americans have to forego health care in order to put food on the table or keep a roof over their head. That is unacceptable. Our health care system must be reformed, and as a member of this subcommittee, I look forward to working with my colleagues and the American people to make it happen finally. And I look forward to hearing from our panelists today about this important issue and their insight into how we might go about making this become a reality. I thank you, and I yield back the balance of my time.
Thank you. The gentleman from New York, Mr. Engel.
Well, thank you for holding, Mr. Chairman, this hearing today on making health care work for American families. It's clear to so many of us that our health care system is broken. For years, we've been talking about the 47 million growing uninsured Americans and 25 million underinsured Americans, and it is apparent that some people have come to accept this tragedy as a fact of life, that some people are fortunate to have health coverage, and some people, millions and millions of people, aren't, so too bad for them. In truth, it has often been said, everybody does better when everybody does better. We can do better. The status quo is no longer acceptable. In the first 2 months of the Obama administration, we made significant strides toward improving our current health care system. Our reauthorization of the state children's health insurance program provided health care coverage for 11 million children, preserving coverage for the roughly 7 million children already covered by SCHIP, and extending coverage to 4.1 million uninsured children who are eligible for but not enrolled in SCHIP and Medicaid. We made a solid investment in modernizing our health care system in the stimulus by making key investments in health information technology. Widescale adoption and implementation of health information technology will be a fundamental part of any true health reform bill. The $19 billion designed for HIT will eventually enable our health care system to save billions of dollars, reduce medical errors, and improve quality of care. Many of the measures included in the stimulus, ranging from extra Medicaid funding for states to subsidizing COBRA insurance for unemployed workers, will help to stop the bleeding during this terrible recession. Long-term, though, our health care delivery system requires a comprehensive implementation of sustainable reforms in order to succeed. The President is off to the right start with his commitment to health reform. His $630 billion down payment towards health reform, coupled with the administration's 8 principles, will guide Congress in our joint efforts to revamp our health care system. With the United States paying more than $2 trillion a year for health care, we should ensure that we are getting what we're paying for, a world-class health care system for our nation's hard-working citizens. And yet, it is clear that our payment systems are flawed. As MedPAC has noted in its testimony today, Medicare's fee-for-service payment system rewards more complex care without regard to the value of this care. Bizarrely, for those with multiple ailments, coordination among providers is not encouraged financially by Medicare, where clearly coordinated care would result in improved health conditions. Mr. Chairman, thank you again for holding this hearing. You've really been a champion in pushing these reforms, and I commend you for it. I look forward to the work ahead of us this spring and summer on reforming and designing a quality health care system. And I yield back the balance of my time.
Thank you. Gentlewoman from California, Ms. Harmon.
Thank you, Mr. Chairman. I'm very pleased to be a new member on this subcommittee, though not new to these issues. I am the sister and daughter of physicians, and I recall very well, half a century ago, how my father handled his general practice of medicine. He was the neighborhood physician. He made house calls most evenings. He served 3 generations of patients in a small group practice in Culver City, California, during the time he practiced medicine. I was very proud of what he did, and now I look back on it and it seems an Ozzie and Harriet alternative reality. We can't go back there, Mr. Chairman, and we surely have to grapple with the problems described by so many of our colleagues this morning. But I must commend you for the panels in this opening hearing today, and I especially want to mention Doug Elmendorf and congratulate him in his new role as Director of CBO. He has been a valuable asset to many of us as we have tried to grapple with budget issues. And what I think he brings to this is obviously an understanding of the cost piece of health care, but also great compassion for the need to extend coverage to as many as possible in our country. So I commend you for this hearing. I commend our witnesses, and count me in on all plots to make a huge down payment on solving this problem this year. I yield back.
Thank you. And I believe that concludes our opening statements, and so we'll now turn to our witnesses.